So what we're going to be talking about is pain assessment, but specifically chronic pain, not acute pain. And chronic pain is very, very difficult to assess and deal with. The aim of the psychophysiological assessment is to produce information that's not available through other assessment approaches, which provides highly specific information about physiological systems and responses causing and or sustaining pain problems. This information may be used to guide the choice of very specific psychophysiologically based interventions which rectify the identified problem and thus relieve the pain. So the idea of the assessment here is to figure out what to do with someone who's got chronic pain. So if you look at this figure, look at the person's leg. This is a person whose leg has been amputated just above the knee. And the person is feeling all kinds of pain that appears to come from the phantom, the place where the limb used to be. So this is an ideal way to try to figure out what's causing chronic pain. And what you see in the little diagram here is we're recording from the residual limb, the stump, to see what's going on in it that might cause pain that's referred into the phantom. And what we find is that there's all kinds of stuff going on in the stump. The nerves that used to go to the part of the limb that's been amputated still run through the stump and they're still working. So if they're stimulated in the stump, people think that the pain is coming from the part of the limb that they don't have. That's simply how we're wired. There's a little figure in the top of the head called a homunculus, little person. And for every spot on your body, there's a spot on the homunculus. So let's say that you pinch your finger. Then the finger and the homunculus will light up. But think of hitting your elbow. You're walking out a door and you smack your elbow. You feel tingling and pain running up and down your arm. You didn't do anything to your hand and your arm. You simply started the signal where it normally doesn't start. But the homunculus has no way to know that. So this is a crucial, crucial part of looking at pain. There's a lot of things that cause and maintain chronic pain. So let's say somebody is under stress. Do any of you ever get under stress? Everybody does. Stress leads to anxiety. It leads to a number of different things, like increased muscle tension, decreased blood flow to the periphery. Your intestines don't work the way they were working before. So you get all kinds of problems. When you keep your muscles too tense for too long, they hurt. And I'll show you that in just a second. My dog's trying to get out of the house. So let me just let him out. Okay, I'm back. Boss is out. So think of a cycle: stress, anxiety, increased muscle tension, leading to pain. And there's all kinds of magnifiers. Anxiety is a magnifier of your pain. Depression magnifies your pain. And there are chemical things that happen when we're under stress. We become inflamed. Half of the pain receptors in your body do not respond to stimuli like stubbing your toe unless there's inflammation in the area. So if you've got an inflamed foot because of stress and you stub your toe, it'll hurt twice as much about as otherwise. Stress also leads to the release of cortisol, which is a normal reaction. But if you keep being under stress, you get more and more cortisol released, and that sets off a whole chain reaction that magnifies your pain. So let's stop looking at the slides for just a moment. Let's talk about pain and muscle tension. When you're under stress, your jaws tense up. So why don't you feel your jaw as you tense up? Okay, just go ahead and clamp your jaw. Many people don't realize that they keep their jaws only 5% or so tenser than they should be. When you clamp your jaw, if you keep it tense long enough, it'll hurt, even just that little bit. Now go ahead and clamp your jaw again and feel your temporal muscles over here. So you clamp your jaw, feel the muscles over here. That causes electrical signals to go across the top of your head. It also causes tension headaches. So when your jaw is too tense, these muscles are too tense, and you get a tension headache. If you're sitting at a computer all day and you lean forward like this, you tense up the muscles here and you force your head to rise up. And that causes a lot of tension, which causes problems, which cause tension headaches. So tension headaches happen from stress and posture. And we have to have a way to evaluate that. So I'm going to share my screen again. And what I'm trying to show you is a muscle tension pattern here. And let's see if we can get it working. Well, wouldn't you know it, the system's not working right now. I dropped it on the floor when I was letting the dog out, and it pulled out the sensors. So just give me a minute and we'll see if we can get it working. If not, we'll live without it. Here we go. Sorry about that. Notice I neatly blamed the dog for the problem, right? Anyway, I have sensors attached to my forearm here. Make believe they're on my forehead. So if I tense up my forehead, in this case, my arm, you see the muscle tension go up. And if I let my forehead relax, it goes down. This is what you get with your jaw. When we want people to recognize how tense their muscles are, we show them this display. For instance, normal for the forehead would be way down here. So what we would do is we would have somebody try to relax their muscles enough to go down to a normal level and teach them what it feels like. So this is a key way that we evaluate chronic pain in the jaw and the head is we look at how much muscle tension there is, and then we can stress somebody out a little bit and see if it goes up, or we can look at their posture and see if it goes up. So that's a standard psychophysiological recording system. Let me go back to sharing the screen. So the system that I was just showing you is right here. Most of the systems look pretty much like that, and they can record what's going on in your body. They record blood flow by picking up temperature, because all of the heat that comes out of your extremities is caused by near surface blood flow. They pick up blood pressure. They pick up your heart rate and variability in your heartbeat. They pick up how much you're sweating, all kinds of stress responses. We send it to any kind of a computer. So this is an antique, but they all work. And the little system I showed you, there's all different kinds of them. They just plug into the computer and they work fine. So here's some psychophysiological recording devices. This is the one I'm attached to now. It's called a Nexus. This is an Alive. This is a Thought Technology Infinity unit. And they can all record multiple channels. So let's say that we're going to do an assessment of somebody who's hurting. If you're breathing incorrectly, we can record your breathing by having a belt around your chest and your abdomen. If you breathe slightly too quickly, habitually, we're not talking about hyperventilation here. We're just talking about breathing slightly too quickly for a long time and slightly too shallowly. If you do that, you'll set off a tiny version of the fight, flight, freeze response. So you'll always be a little anxious. And for a great many people, that leads to non-cardiac chest pain. So if we find that somebody is breathing incorrectly and we retrain them to breathe correctly, for almost everybody, the non-cardiac chest pain goes away. We can record from somebody's forehead. So remember I told you I was recording from my arm, but imagine that we're recording from the forehead, right? We're picking up changes in tension in the jaw. because when you tense your jaw, even a tiny little bit, less than you can consciously feel until you're trained, you tense your temples, and that leads to a signal going across your forehead. Here we're recording somebody's skin temperature. We're just picking up from a thermometer, an electrical thermometer that's attached to the finger. If your fingers are cold, that lets all kinds of problems start, like migraine headaches. We can figure out if you're so cold habitually that you're likely to get migraine headaches. If the assessment shows that that's likely to be the case, you get training to increase your fingertip temperature, and that prevents migraine headaches from coming on. Well, you might say, hey, I was talking about controlling muscle tension in the jaw. I showed it to you on a screen that we can record it. That's something people could probably learn. That makes sense. But preventing migraine headaches by teaching somebody to raise their fingertip temperature, how believable is that? There's a reflex. If your fingers, toes, and nose are cold, the central cerebral arteries in your skin have not the central cerebral arteries in your skull, rather, under your skull in your brain, have too much blood flow, and it allows a migraine headache to come on. If we increase the blood flow, that reduces blood flow in the central cerebral arteries, and the migraine headaches don't come on. Well, does that really work? There are hundreds of well-controlled studies with large populations of people that show that if you learn to raise your fingertip temperature, the migraines don't come on. And the follow-ups of the various studies are between 5 and 10 years. So these techniques work as well as any preventive migraine drug. But you have to do the assessment. If you look down at the person's fingers, we're recording how much they're sweating. You sweat more when you're nervous. So we can pick up when somebody is under stress. So we have all these different things that we can record. And if you look at the output from the recording, when we're doing an assessment, you see a raw signal, like this is muscle tension from that gentleman's forehead. This is how many microvolts, millions of a volt he's putting out. And you can see whether the signal is normal or not. We record respiration. This is a pattern of breathing. We can tell whether he's breathing too deeply or too shallowly. We look at the heartbeat. Is there a normal amount of variation or not? If your heart doesn't beat irregularly, you're in trouble. Your heart has to beat irregularly. There has to be a lot of heart rate variability. If there isn't, literally hundreds upon hundreds of articles show that you're likely to get sick. And one of the things that happens is that this sets off the sympathetic nervous system so that it's very aroused, and you get a lot more inflammation, and you get a lot more problems with your gut. So you get irritable bowel syndrome. We're recording temperature, and GSR is sweating in this case. So I told you we'd get back to amputees. So here's a lady who's missing her limb. You know, from here down, it's missing. This one's intact. And what we're going to do is we're going to record from right here, from the stump, the residual limb, and over here, same place, but on the intact limb. Now, let's say that you're walking into a kitchen and you don't realize that your stove is on, and you reach out and you touch the hot stove and you jerk back. That's a reflex, right? But the reflex isn't just the hand you jerk back. There's a little tiny reflex on the other side. So if you feel a shot of pain, you know, just bam, like that, that seems to be coming from your leg, you'll jerk your leg, but the other leg will move too. So we can tell whether this is a reflex reaction to pain that we're picking up or whether it's something else. So here's the woman's intact limb. There's nothing happening. It's just going along. This is a raw muscle tension signal. But here's the stump that you were just looking at. See the muscle tension changing? When she feels pain, first the muscle tension goes up, then a split second later the pain comes on. When the muscle tension goes down, the pain disappears. So again, if this was a reflex, if something else was causing the pain, you would see a reaction here, but we don't see it. So it's actually spasms in the residual limb that are causing the phantom limb pain. So what do we do about that? We train people to control the spasms, to be aware of when a spasm is starting and to not let it happen. Somewhere around 80% of people can learn that skill, maybe a little more. To the extent they can learn that skill of stopping a spasm, that stops the phantom limb pain. And in our studies, people who had cramping descriptions of phantom limb pain were able to stop having phantom limb pain, even if they had had it for 30 years or more. It was just gone after the training and it doesn't come back. Okay. Eunice, I don't know if people can ask questions. Are there any questions about what I've been talking about?
They have, they can ask questions. They currently have not asked any, but if they do, I can go ahead and interrupt you, or we can also leave them for the end of your presentation.
Either way you want it.
Okay.
Okay, so we talked about headaches. So here we are recording somebody's forehead. Remember that it's not muscle tension in the forehead we're worried about, it's muscle tension in the jaws, which cause tension in the temporal muscles, which cause problems across here. We're also recording from the trapezius muscles and the neck. You can sort of see a sensor poking out there. So as I showed you live on the screen, we can tell how tense these muscles are, and we can tell if they're abnormally tense. We know what's normal, we know what's not, and we bring this to people's attention. We train them not to be too tense for too long, and that prevents tension headaches. If they have the tension headaches because the trapezius is too tense, then we're training that as well. This lets people know that they're tensing up. So if they're tensing up because of a stress response, because something's going on at work or whatever, they know that, and they can be treated with typical psychological interventions to reduce their reaction to the stress. But most people that get tension headaches due to habitually keeping the jaws too tense, poor posture, or stress reactions can learn to not tense up more than they should. And again, there's huge numbers of studies that show that this is highly efficacious. So I hope that's making sense. Um, Going on to pelvic floor pain. A lot of people's pelvic floor hurts. This is a really serious problem. Very often it goes along with urinary incontinence. So let's say we're recording from the pelvic floor. This is a normal recording, this green line here. It's, it keeps changing as you tense your pelvic floor and let it relax. But if you have pain there, it's unstable. It keeps going up and down, and there's much more tension than there should be. And as I said, if you keep a muscle too tense for too long, it hurts. So we train people to go from this kind of pattern to this kind of pattern. The key is that we can recognize this and figure out what's causing it. I mentioned blood flow before, blood flow causing pain. If you have too little blood flow in an area, that area starts to hurt. Like if you sleep on your arm and you cut off your blood flow to it, it really starts to hurt. It tingles, everything else. If you continue to have blood flow reduced in a limb over weeks, it starts to die. So you have not only the pain from reduced blood flow, but you have pain from the limb starting to die. When we want to record blood flow in a limb, we use a camera called a video thermograph. It's taking a heat picture of the limb. Remember, I said all of the heat coming out of your limbs is caused by blood flowing right near the surface. So here's a picture of a hand. Right here, there's a blister. See the little blister over there? That's warm, that's inflamed. So we can pick up inflammation under the skin. We can evaluate whether somebody's inflamed. Remember, if there's inflammation, twice as many pain receptors work, you get twice the pain. Of more importance, we can tell when there isn't enough blood flow in an area so that somebody will be hurting. Problems like CRIPS, reflex sympathetic dystrophy, which happen when the sympathetic nervous system is too active in an area, so it clamps down the blood vessels. The actual lumen of the blood vessels gets smaller. So not enough blood gets there, and you have very little blood going to an area. It looks different when you measure the temperature. So we can figure out that something is going on. And then we can guide an anesthesiologist to give a block that will increase blood flow to the area, or we can train people to increase their blood flow to the area. This is a double amputee. And warm is more blood flow. Greens and blues here are less blood flow. So this person has a reasonable amount of blood flow in this residual limb, and they have no phantom limb pain. This one is pretty cold, and they're rating their phantom limb pain as a 2. And this is what we see. So we're able to evaluate what's going on. We can look at this over many different days. So here's somebody who's lost a finger, okay? This finger was amputated in an accident. Here, both hands look like they're about the same temperature, and this person has no phantom pain. Here, this area is cooler than here, and they have mild pain in the phantom. Here, it's very much colder than the paired area over here, and there's lots of pain. Here, there's almost no blood flow. It's the same color as the background. This area will die if it remains like this, and the person has severe pain in this area and in the phantom. So again, this is an evaluation. What about musculoskeletal low back pain? About 80% of adults get low back pain every once in a while. It's intermittent. It'll go away after a while if you don't do anything dumb to it. Most of the time, it's caused by strains and sprains, but there's a muscle tension component. So here are sensors on somebody's low back. And what we do is we record people in different positions, like bending and rising, sitting supported, sitting unsupported, laying down. We're recording people in different positions and at different levels of pain. What we're looking for is a correlation between how much muscle tension somebody is putting out and how much pain they're in. And we get a very high correlation between how much pain you're in and how much muscle tension you're putting out in your most painful position. This gets a little more complex. So I'm sort of going to the next level of the evaluation now. What if the pain in your back is caused by arthritis? If you have pain, you tense your muscles. That's a normal reaction. So let's say you have this much pain from arthritis. You'll have a magnifier up here due to muscle tension that happened as a reaction to the pain. And this happens all over the body. Regardless of why you've got pain, you'll have extra muscle tension. And you'll have different stress responses. But let's stick with muscle tension for a minute. So if most of the pain is caused by muscle tension, we pick up a high correlation between muscle tension and pain. If the pain is caused by something else, we can see how much is magnified. and we can help people reduce that. We can help reduce the magnification.
Dr. Sherman, we did
Yes.
have a couple of questions, and I feel like this is a good point for that. So if they do have a lot of pain and they're trying to decrease it, one of the questions was, what is the therapeutical goal for EMG? So they said that I use 5 microvolts. Is that right?
Please clarify the question.
I guess they're trying to see if what like a good target would be for minimizing EMG. Is it
Oh,
supposed to be like 5 microvolts or such if they're training it down?
okay. The norms for how much muscle tension there is everywhere in the body are known very well. There are huge studies that say how tense your jaw should be when it's relaxed. How tense should your trapezius be? How tense should your forearm be? So we know what normal tension is. What you're doing is you're helping people work towards normal tension. Let me bring up the screen again. Microvolts are millionths of a volt. So what you're seeing on your screen, everybody's seeing the muscle tension recorder here, right?
Yes.
Okay. So microvolts are millionths of a volt. Normal for the jaws is between 3 and 5 microvolts. You're always going to see some microvolts because of noise in the system. So what we do is we train people to recognize when they're tensing up and relaxing down. Okay. They have to learn to recognize what the tension feels like. So it's not just a matter of a goal, of setting a goal. Like this little dashed line, I had set a goal of about 4 microvolts, and the person is reaching it. But that's not what you do. What you do is you shape somebody's behavior. So let's say the lowest they can get is 10 microvolts. So you set a line at 10 microvolts, and then you slowly lower the line down further and further so that they can begin to reach a goal of normal. But this is kind of useless because people aren't hooked to a machine all the time. What you do is you have people look at the tension level they've got. So let's say tension level is up here around 6 or 7 microvolts. You have them look at this and recognize how it feels. They're using their imagination. And then they close their eyes and they try to go to that same level. And when they get good at that, you have them lower their muscle tension some more and feel what that's like. Close their eyes, be able to reproduce it so that they know what the muscle tension should feel like. And that's what your goal is people learning to recognize their tension. That way, if they're having a stress response and their muscles begin to tense up, they know it and they can relax down. So again, your goal is to teach people how it feels and to work towards normal. Um, let's say that you have pain that seems to be coming from your kneecaps after you've injured one of your knees. There's 2 muscles that control your kneecap that are up in your thigh, the vastus lateralis and vastus medialis. And if they don't pull with the right pattern of tension at the right time, your kneecap gets pulled out of place and you hurt. It doesn't do any good to teach somebody to strengthen both of these muscles and pull exactly the same. You have to train the pattern to be normal. And you can pick up that pattern from a normal knee, if the other knee is working normally, or from what we know is normal. So very often you're training patterns of tension, if that makes sense. Are there other questions about this?
Yes, I have a couple of other questions. Adelita was asking about what the interventions would look like, but I think you kind of answered that by explaining the previous question. Adelita, if you have something that you want to specify, that would be great. There was a follow-up question of um, neuropathic pain, like
Okay,
how that would
hang
help.
on. Let's handle the first one.
Okay.
Um, what these recordings are showing us, remember, muscle tension is only one. Everybody responds to pain differently. I mean, to stress differently. Everybody has different reasons that they hurt. So if you have irritable bowel syndrome, a vast number of people have a stress reaction. And what we do is we train people to have good heart rate variability, which reduces the sympathetic reaction, the sympathetic nervous system's reaction, and calms down your gut. So there's all kinds of um, different interventions for um, different problems. It depends on what the assessment has showed. Muscle tension is only one of the interventions you would use. Very often you use cognitive structuring when you discover somebody has got, um, um, let's say, non-cardiac chest pain, and we discover that it's due to stress reactions. So it's not always a biofeedback kind of thing. All right, neuropathic pain. Neuropathic pain um, is usually a nightmare. I talked about the homunculus a little bit. Let's say that we're talking about pain in your thigh, in the back of your thigh, that's starting to run down the back of your leg. And let's think about the main nerve that serves that area. That's the sciatic nerve. However big your thumb is, the sciatic nerve is about that big. And that's running through your butt. And there are muscles that control your hip, that control your leg turning in and out. The sciatic nerve for everybody runs differently. For some people, it runs over those muscles. For some, it runs under them. And for some, it goes right through them. If you pinch the sciatic nerve, let's say you've got a fat wallet in your back pocket and you're sitting on it for too long. So you pinch the sciatic nerve in your butt. That causes pain that appears to be coming from your thigh and the back of your leg. So that's really one type of referred pain rather than a neuropathic pain, a standard neuropathic pain. But that's most common for what we pick up. when remember I talked about the homunculus, that if you hit your elbow, you feel the pain up in here as well as in your elbow. That's because a signal that was supposed to start here instead is starting here, and the homunculus doesn't know that. So when you crimp the sciatic nerve, that's what you get. A more traditional type of neuropathic pain, um, let's say that you have a heart attack. You feel it in your left shoulder and jaw, right? That's another situation. And that's an area where psychophysiological assessments don't help very much, other than showing that there's nothing particularly wrong with the area where you think the pain is coming from. Uh, did that help answer the question?
Yes, thank you. We have two more questions. The next one is, what is the pattern or response of psychophysiological assessment in complex regional pain syndrome, fibromyalgia, or ischemic brain injury, stroke? I think it's
Um, we can record, well, first of all, for complex regional pain, complex pain syndromes, let alone CRIPS, regional pain. I talked about RSD CRIPS already, where we can pick up that there's not enough blood flow to a particular area, and we can train people to increase it, and we can guide anesthesiologists to give blocks like a beer block to that area to increase blood flow, so they know where to do the beer block and we know where to do the training. um, when people have complex pain in many parts of the body at once, you have to do a very careful evaluation. Pain all over the body very often is due to people breathing wrong. When you retrain the breathing, pain in many of these areas goes away. So it depends on what you actually mean by a complex regional pain syndrome. Did I answer that question? Okay, so stroke. Strokes cause you to lose control of muscles, and there's very little evidence that biofeedback, well, the psychophysiological recording tells you which muscles are most effective and whether there's any control left. Because let's say that you've got a stroke where this arm can't move. When we do a muscle tension evaluation, we can see whether you're tensing a little bit, but not enough to move your arm. And we can train that up so that you get more motion. Or if there are spasms, we can show people the spasms and help them reduce the spasms. We can do that, but there's another area that the evaluation helps in. When someone has a stroke, very often, 6 months later, the arm doesn't move at all, or the leg moves at all. It's almost locked in place. But very often there's been recovery and the person doesn't know it. They're doing everything with their other arm. If we tie down the good arm, we can train the supposedly useless arm to do more and more, but not fine motor control. We're not that good, but we can get bigger motor movements.
That's very interesting.
Okay.
Um,
Did I answer the question though? Did I misunderstand?
mm, I don't think so. I think uh, they answered. They haven't put any follow-up questions. Oh, yes, they said yes. Okay. Last question is, how do you assess and deal with some pain symptoms? Were they related to trauma experience?
Um, Poorly. Um, PTSD, things like that. Um, we can look at brain waves. I didn't talk about brain waves and pain here because the research studies are not as robust as everything else I talked about. Everything else that I talked about, there's dozens of excellent studies and more than dozens in most cases. If you have PTSD, um, very often the traditional approaches don't work. The traditional psychological approaches like flooding don't work. What we can record are brain waves and how the different parts of the brain are interacting and how you're reacting to stress, and retrain people not to have such big reactions to PTSD. But I don't want to give you the idea that that's absolutely proven. Hang on, I'm disappearing for a second, letting my dog in. Be right back. Okay, here I am again. Sorry. The dog's my boss. He wants to go in and out. I got to let him in and out. Okay, so for things like PTSD, we do fairly poorly, but there are a few studies that show that we can really help with specific problems. Um, for anxiety related pain problems, very often we can pick up anxiety responses in the brain and help people learn to control those. Okay, I answered that as best as I could. What else?
Perfect. Miriam asked another question. Had you ever treated pudendal neuralgia?
No, I haven't. Other people have, but there there aren't a lot of good studies on that. Um, I've left out a lot of pain problems because if you go and do a literature search, you're not going to find a lot of good studies. Like I didn't talk about cluster headaches. I talked about migraine and tension headaches, where we have excellent evidence. For cluster headaches, um, we can get a very good idea that the cluster headache is not related to tension or migraine, but we can't help the cluster headache. Um, so et cetera, et cetera. Um, if you folks want to learn more about pain assessment and intervention, the Behavioral Medicine Research and Training Foundation gives lots of courses in this. Our courses are approved by the APA for CE credit. You can just go to biofeedbacktraining.org and find courses anywhere from just a few dollars for a few CE credits up to many more credits. So that's basically it.
All right. Thank you so much, Dr. Sherman, and thank you everyone who showed up today and for your interaction and your patience for the beginning of the webinar. Again, thank you, Dr. Sherman, for your time. It's very interesting to hear about the various ways to assess pain. Um, so thank you very much.
Okay, thank you very much for having me here. And someone is saying, thank you for the interesting talk. I appreciate getting the feedback. And Eunice, if you could let me know about any feedback and how many people came, I'd really appreciate it.
Yes, I can totally do that.
Okay, goodbye then. Thank
Bye.
you.
Thank you.